Hello, everyone. Welcome back to Recovery with Nurse. Today, we want to take a deep dive into how nurses give report to each other using the SBAR form. This video is mainly for those who are in nursing school, going through their clinical rotations, new grads, or simply for those who are interested in the nursing field. And let's get started right away. Okay, so today we have an SBAR sheet. SBAR stands for Situation, Background, Assessment, and Recommendation, which we'll get to that later. Okay, so let's start from the top. We have a room number, primary team, and a consult team. So let's say the patient came in for heart failure, then we'll say cardiology, simply cards. Consult, we can have internal medicine, nephrology, let's say infectious disease, and so forth. We'll apply a patient label sticker right here. We'll determine if the patient is full code, whether they want full resuscitation, do not resuscitate, do not intubate, or intubate. We'll list their allergies here. Let's say they're allergic to penicillin, iodine, or shellfish, and so forth. We'll apply their core measures if they're on any, pneumonia, CHF, MI, or stroke, for example. If they're transfusion free, we'll indicate that. Say yes or no, simply. We'll indicate their safety precaution. Let's say they had a history of fall. We'll say yes. Then we'll indicate the date and the reason for the fall. If so, we'll apply a yellow band, high fall risk yellow band, and yellow non-skid socks. We'll always put bed alarm for those high fall risk, and apply sitter and restraint if appropriate. Here we have isolation precaution. Let's say if they're on contact precaution, VRE, ESBL, C. diff, and MRSA. Droplet. Let's say they have a simple flu or RSV, or airborne. Let's say we're ruling out TB or tuberculosis. Here we have some other precautions. Let's say they're immunocompromised, then they need extra precaution. Chemotherapy, radiation, and nuclear date. That's maybe more so the staff, so we can ensure the staff is safe from radiation and unnecessary contact with the patient. We'll indicate if they're on aspiration precaution, seizure precaution. This is big, CHG. If they have any central lines, indwelling catheters, or they have a operation that day, then we'll indicate the date and time there. Or if they need a simple bed bath for those that don't have any central lines or indwelling catheters. So today maybe they came in for heart failure or shortness. We'll indicate their chief complaints of shortness of breath, bilateral lower extremity swelling, and their main diagnosis, heart failure, CHF. We'll indicate their background here, their medical surgical history. Patient may have diabetes, hypertension, coronary artery disease. Maybe they have some stents. And we'll, in that little symbol, a line across, and C, that means with. That with an S means without. So let's go through. Maybe they have some sleep apnea with CPAP, continuous positive pressure, air pressure, machine, maybe some anxiety, depression, hyperlipidemia, BPH, and we'll indicate their cancer history. Rectal CA, then maybe we'll indicate here. CA means cancer. Here under assessment, we have neurologic assessment. The patient is luckily awake and alert. Will indicate what they're oriented to. Are they oriented to person, place, time, or event? Or if they're oriented to all four, we'll simply say times 4. And when we're giving report, we'll usually say A and O times 4. They're English speaking. They may be hard of hearing with hearing aids. We'll indicate whether they have left, right, or bilateral hearing aids at the bedside. They may be glasses or they may be blind. Here I like to go through top and bottom, meaning top, head, chest, abdomen, and so forth. People have their preferences to go down this way, but to me, it only makes sense to go from top to bottom. So here we'll go to respiratory. We'll indicate if they're on room air, then we'll say room air. Maybe they need some supplemental oxygen during the nighttime, maybe 1 to 2 liters nighttime, and they are saturating 95% or above. Maybe they may have CPAP, either their own equipment or at the bedside, provided by the hospital. CPT simply means chest physiotherapy. That'll be done by RTs, respiratory therapists. They may have a trach or laryngectomy patients. Then we'll indicate what type and size. Let's say they have Shiley 6. Maybe the patient has a lobectomy, pneumothorax, then they'll come with chest tubes. So let's say they may have 2 chest tubes, maybe a pigtail, 1 pigtail and 1 blade. We'll indicate this type of suction, either dry or water suction. So within a dry suction, we'll have to indicate whether they are water seal or they may require extra suction. Let's say they are in minus 20 centimeter, 30, and so forth. And that'll be determined by the provider. Here we have cardiovascular system. Are they on telemetry? Or if not, then they are a med-surg patient. We'll indicate the parameter of the blood pressure. Maybe they're hovering around 140s and 160s. Indicate their heart rate. Are they sinus rhythm, sinus tach, sinus brady, AFib, and so forth? Do they have a pacemaker? Is it A pacing, V pacing, or AV pacing? For the patient with heart failure, they'll most likely have some edema. And are they pitting? So we'll indicate their bilateral lower extremity pitting, edema, and how much. Is it +1, +2, or 3? Here we have some pain assessment here. In the case of maybe orthopedic case, they're most likely on a lot of IV medication, such as Dilaudid, 0.2 milligrams Q2 hour, for example. PO medicine, let's say they're on oxycodone, 5 or 10 milligram Q4 hour. After surgery, they might have a PCA, or patient control anesthesia, epidural, or ketamine. Let's say the patient is R1D1, let's say ropivacaine and Dilaudid, 1 0.2 milligram PCA Q20 minute. We'll indicate that there. So they have ropivacaine 1 and Dilaudid 1, and that's continuous. The patient can have 0.2 milligram every 20 minutes. They can press that button. Let's go through a gastrointestinal section here. If the patient has trouble swallowing whole pills, then we'll indicate that we have to crush their meds. Diet. Are they on regular diet? Carb control diet for those with diabetes. Heart healthy diet for those that have any cardiovascular issues. Are they on fluid restrictions? If they came with heart failure, they might be on fluid restriction to maybe 1,000 ml per day. Or are they on NPO? NPO, accept meds, but they might have some ice strips. It all depends on the patient. The patient might have an NG tube, a nasogastric tube. So we have a Dopov, G tube, J tube, or GJ tube. And we have an NG tube insertion date. And if the patient has an ileus, meaning an obstruction in their GI tract, they might be on wall suction. So we'll indicate, are they on low intermittent wall suction, low continuous wall suction, or are they on gravity, maybe to a little bag? They might be on tube feeding, and they might be on continuous feeding or cyclic feeding. For example, they might be on cyclic feeding from 8 o'clock in the morning to 8 o'clock at night, 2000. And in the case of a diabetic patient, they might be on diabetic source. We'll most likely start at a really low rate at 10, and depending on their goal, determined by the registered dietitian, maybe their goal is 45 cc an hour. So we'll increase by 10 cc every 4 hours up to that goal. We'll flush their tube 30 cc of saline or water Q4 hour. Their last BM, let's say they had a BM a few days ago. If they have colostomy or ileostomy, we'll indicate that there. And when was that bag changed? Let's say the bag was changed 2 days ago as well. Do they have bowel sounds? Are they passing gas? Okay, so here we have a GU, genitourinary system. Will indicate whether they're voiding fine, voiding okay, or do they have an indwelling catheter, a Foley catheter. Most likely, post-op, the doctors would like a strict intake and output. If they do have a Foley catheter, the insertion date, super critical to know, and indicate why they need an indwelling. Are they on, perhaps they're on epidural, so they're not able to void on their own, so they'll say retention. Or in the case of urology case, then we'll just simply say by urology. So here we have a few options how they void. Are they incontinent? Are they anuric, meaning no urine output at all? Or oliguric, meaning less output for those with HD or PD patients. Nephrostomy tube is common too. Will indicate if they're on the right side, left side, or both. We also have suprapubic catheter. And in the case of urology patients with a neobladder, meaning new bladder, they may require some irrigation. Let's say they irrigate Q4 hour with 120 cc of normal saline or until clear. That's pretty common practice. If they're on HD, we'll say HD, last dialysis yesterday. Do they have an AV fistula with brew or thrill? Do they have a permacath, more of a permanent catheter, or vas cath, or the temporary catheter? Will indicate, let's say they have a right upper chest, permacath. It's very common to have some drains post-op. We have a Jackson-Praxton drain, a biliary drain, a pigtail, wound vac, or hemovac. Let's say they came out of a surgery with 2 JPs, maybe on either abdomen. We'll say right abdomen, left abdomen, and maybe the right one put out 20 cc overnight, and this one 50 cc overnight. The patient has a wound vac on the sacrum. Then sacrum is in minus 125 millimeters per mercury, minus 75, or so forth. And when it was changed, maybe PT wound care changed it yesterday. Here we have integumentary or skin. Believe it or not, skin is the biggest organ in our body. Let's say the patient has a mid-vertical abdominal incision. Well, let's say mid-abdominal vertical incision. They might have some staples, some stair strips, sutures, or dermal bond. It will indicate the type of dressing here. Maybe Xeroforms, Vaseline dressing, maybe Telfa, which is a non-sticky dressing, ABD pad, and some tape. I think that'll suffice. And maybe they have an abdominal binder. Here we have a score based on their risk of skin injury. Maybe the patient is bedbound, so we'll need to turn Q2 hours, or do they need specialty beds? If the patient is an elderly, they're prone to skin tears, bruising, or any skin abnormalities. Does the patient have any rash anywhere? And here we have pressure-related injury location. Okay, pressure-related injury that is occurred in the hospital are called HAPI, and HAPIs are really bad. Hospital-associated pressure injuries are really bad. Maybe the patient has a non-blenchable redness in the sacrum. We'll say stage 1 sacrum. But if they have a stage 3 or 4 anywhere, then PT wound care is consult automatically, and they will follow up with the patient. Here we have musculoskeletal and the mobility. Think of that as mobility. How active are they? How much assistance do they need? Do they need minimal assistance, moderate, or max? Or do they need 2 people? Are they steady? Are they unsteady, or unable? Does a patient need physical therapy, occupational therapy, or speech therapy, and a swallow eval by speech? Here we have some IV access, peripheral IVs, peripheral inserted central catheter, or do they have a port, midline, internal jugular? Will indicate maybe they have a peripheral IV on the right forearm. And in this case, we have a 20 gauge, started today, and it's saline locked. Or are they on maintenance fluid? Let's say they're on NS at 50 ml per hour. Maybe they have a TPN, and that you must have a central line or PIC. Or PPN, peripheral. Then we're okay with a peripheral IV. Are they on continuous? Maybe they're on 60 ml per hour continuous, or cyclic based on the pharmacy and doctor's orders. For those with diabetes, we need to control their blood sugar. ACHS, so before meals and at bedtime. ACHS. In the case of TPN or PPN, we might have to check their blood sugar every 6 hours instead of every meal, because that doesn't make sense if they're only on TPN. And AM labs. Does a nurse have to collect the labs, or can it be collected by a lab technician? In our hospital setting, nurse collect means the patient has a central line, and the lab technician will draw everybody else, those with peripheral IVs. Nurses can draw, but that's our hospital policy. Here we have pending procedures, tests, and orders here. So we'll indicate they're due for MRI, chest, or let's say CT of abdomen and pelvis. It will indicate if it's a routine or stat. And the plan. What's the plan for this patient? What's their dispo plan? Are they going home? Are they going to sniff? Maybe they're going to rehab after. You will communicate with a case manager and potentially a social worker. Okay, there you have it. That was a comprehensive review on how nurses can report to each other using an SBAR. SBAR stands for Situation, Background, Assessment, and Recommendation. If you like the content, please leave a comment below and let me know if there's any other nursing related content you would like me to post. Thanks for watching. See you in the next video.